I'm Dr. Ravi, done my MD Pharmacology from Osmania Medical College, Hyderabad. Today I'm here to discuss about anti-diabetic drugs. Diabetes is defined as a group of common metabolic disorders which shares the phenotype of hyperglycemia. Hyperglycemia is associated with inadequate insulin secretion, impaired insulin action, or maybe both. So how do we diagnose the disease? What are the investigations we suggest? If we measure the overnight fasting plasma glucose levels and we can measure the 2 hours plasma glucose levels, or we can measure the random blood sugar levels, or we can measure the glycolated hemoglobin levels. So plasma glucose levels, if we measure the overnight fasting plasma glucose levels, if it is less than 100 milligram per deciliter, then it is normal. Between 101 to 125 mg per dl is impaired glucose tolerance. Impaired glucose tolerance. If it is more than or equal to 126 milligram per deciliter on more than one occasion, then it is diabetes mellitus. Or we can check the 2-hour plasma glucose level. In glucose tolerance test, we ask the patient to take glucose orally. If we check the plasma glucose levels 2 hours after oral intake of glucose, if it is less than 140 milligram per deciliter, then it is normal. Between 141 to 199 milligram per deciliter is impaired glucose tolerance. If it is more than or equal to 200 milligram per deciliter, then it is diagnosed as diabetes. Or we can check the random blood sugar. Random blood sugar means we can measure the plasma glucose levels at any given point of time. If it is more than or equal to 200 milligram per deciliter along with the symptoms, then it is diabetes. Or we can check the HbA1c, glycolated hemoglobin levels. Glycolated hemoglobin will give the information of past 3 months glycemic control. So if it is less than 5.6%, then normal. Between 5.7 to 6.4%, then it is impaired glucose. If it is more than or equal to 6.5%, then it is diabetes mellitus. So if we want to know the first 3 months of glycemic control, then we get the glycolated hemoglobin done. But if we want to know first 2 to 3 weeks of glycemic control, then we measure the glycolated albumin levels. So usually it is measured in dialysis patients and in pregnancy. So what are the types of diabetes? Diabetes is classified into type 1. Type 1 is insulin dependent diabetes because it is due to insulin deficiency. Type 2. So though there is enough insulin, the hyperglycemia is because of insulin resistance. So type 2 diabetes is called as insulin independent diabetes mellitus. And we have 1.5 in 1.5 LADA and KPD. LADA stands for latent autoimmune diabetes mellitus of adulthood. So it is a type 1 diabetes, but at the time of presentation it presents as type 2. KPD stands for ketosis prone disease. Actually it is a type 2 diabetes, but at the time of presentation it presents as type 1. Then we have maturity onset diabetes mellitus in young. And we have gestational diabetes mellitus. So it is hyperglycemia in pregnant mother. Now we understood the definition, types and diagnosis of the disease. So come to the management of the disease. So before discussing about the management, it is important to have a look on the glucose homeostasis. So We have two sources of glucose. One is from the intestine, another is from the liver. So hepatic glucose production and food intake. There are two sources. From the source, glucose is absorbed into the blood. From the blood, it is distributed to the tissues. So if you observe one thing here, there is constant optimal range of the glucose is maintained into the plasma. So to maintain this equilibrium, there should be a balance between the amount of the glucose from the source and amount of the glucose taken up by the cell for utilization. So this equilibrium is maintained by or regulated by neurohormonal mechanism. So what happens in the fasting state? So let us have a look in the fasting state. In a fasting state, as my oral glucose is nil, it reduces the plasma glucose levels. So my plasma glucose levels will come down. There is no trigger point for the insulin secretion. So my insulin levels also come down. So alpha cells of the pancreas secretes a hormone called glucagon. So glucagon is secreted only when there is low level of plasma glucose and insulin and during the exercise. So this glucagon promotes the hepatic glucose production. Hepatic glucose production. So how it promotes the hepatic glucose production? By glycosenolysis and gluconeogenesis. Gluconeogenesis. Glucagon has another one action. So it reduces the glucose uptake by the insulin sensitive tissue. Insulin sensitive tissue. So it reduces the glucose uptake by the insulin sensitive tissue. So when my oral glucose is nil, what is happening? Liver producing the glucose and giving into the blood. Now coming to the fed state. So fed state. So in the fed state, this is my small intestine. When I am consuming complex and simple carbohydrates, complex carbohydrates like starch and disaccharides are converted into the glucose with the help of alpha glucosidase enzyme in a small intestine. So these complex carbohydrates are converted into the glucose with the help of alpha glucosidase enzyme. Suppose I am taking 1000 milligrams of glucose. If these 1000 milligrams of the glucose is absorbed into the systemic circulation, immediately what happens? Glucose is osmotic in nature, so it pulls the fluid from every compartment into the vascular compartment. So thereby there will be a hypervolemia. But we don't suffer the symptoms of hypervolemia after taking the food. Why? Because Creator has engineered us in such a way that glucose, before absorbing into the systemic circulation, it sensitizes the epithelial cells of the intestine. So these intestines, L cells and K cells produces incretin. So what is the action of the incretin? Incretin, they induces the satiety, they delays the gastric emptying, they inhibits glucagon, and the GLP-1, incretins are GLP-1 and GIP. GLP-1 stands for glucagon-like peptide, GIP stands for glucose-dependent insulinotropic peptide. So GLP-1 expands the beta cell. So expands the beta cell, and GLP-1 has receptors. GLP-1 has receptors on the beta cell of the pancreas, and these receptors are GLP-1 receptors. So when GLP-1 binds with the GLP-1 receptors through the cyclic AMP, they releases the insulin. So now insulin is released. But this insulin release is very brief period of time. Why? Because incretins are degraded in the plasma with the help of DPP-4 enzyme. So DPP-4 enzyme stands for dihydropeptidyl peptidase 4 enzyme. So what is the action of the insulin now? What does insulin do? GLUT4 receptors. Usually glucose is a hydrophilic substance. As it is a hydrophilic substance, it cannot cross the cell membrane. So there must be some proteins which facilitate the glucose transportation across the cell membrane, and these proteins are called as glucose transporters. And these glucose transporters are divided into sodium dependent and sodium independent. Sodium dependent glucose transporters are SGLT1 and SGLT2. SGLT2 is present in proximal convoluted tubule, and SGLT1 is predominantly present in the intestine. Then sodium independent glucose transporters are GLUT receptors. GLUT receptors are further divided into GLUT1, 2, 3 and 4. GLUT4 receptors has a peculiar feature. So GLUT4 receptors has peculiar feature. They resides inner surface of the cell membrane, but for the glucose uptake they must be brought to the outer surface of the cell membrane. Now insulin has receptors on the outer surface of the cell membrane. When insulin come and bind with the insulin receptor tyrosine kinase, there will be activation of secondary pathway. Eventually what happens, there is a translocation of these GLUT4 receptors from inner surface of the cell membrane to outer surface of the cell membrane. That means now cells are prepared to glucose uptake. By the time this is happening, what happens? Glucose is slowly entering into the blood. So there is a rise of plasma glucose levels. Now what happens in the plasma, in the beta cell of the pancreas, we have a receptors called GLUT1 receptors. Earlier it was thought that GLUT2 receptors are responsible, but now recent edition book says it is GLUT1 receptors. Glucose enters into the beta cell of pancreas through the GLUT1 receptors, and this undergoes glycolysis and it produces ATP. Now on a beta cell of pancreas there is one channel called as ATP dependent potassium channels. When ATPs are formed, this ATP dependent potassium channels are blocked. When it is blocked, what happens? There will be a depolarization of the cell. This depolarization of the cell opens the voltage gated calcium channels. So there will be influx of the calcium. Eventually what happens? There is release of insulin. So insulin is released along with the amylin and C-peptide. Now we understood the glucose homeostasis. Now if we think, where should we manipulate to bring the hyperglycemia to the normal levels? So first and foremost, what are the drugs we can give? We can give the insulin itself, number 1. Number 2, we can give amylin analogs. Number 3, we can block the beta alpha glucosidase enzyme. Number 4, we can inhibit the DPP-4 enzyme, or we can give the GLP-1 analogs like GLP-1 agonist. So this is the 5th one. or we can block the ATP dependent potassium channels. So we can block the ATP dependent potassium channels. So this is the sixth one. So while I was saying about the glucose source, we have another one source, that is kidney. So glomeruli filters the glucose, but we don't find any glucose in the urine. Why? Because glucose is absorbed by SGLT2 receptors in the proximal convoluted tubule. So if we block the proximal convoluted tubule, SGLT2 receptors in proximal convoluted tubule, then whatever the glucose is filtered, it will be passed through the urine. Thereby we can bring the glucose levels to the normal level. Or we can inhibit the hepatic gluconeogenesis and glycogenolysis. So this is the eighth class of drug. Fine. So we have a drug which promotes the glucose uptake, which reduces the insulin resistance. Those drugs are called as thiazolidine diones. So thiazolidine diones or pioglitazones. Then comes to the miscellaneous drugs. These are bromocriptine and covalescellum. So these are the classes. There are 10 classes of drugs. So in the subsequent lecture, we will discuss in detail about one by one drug in a subsequent videos. I hope you understood the concept. Thank you so much for watching. Thank you.